recording? Okay. All right. So for the purposes of the recording, I will repeat myself. So today we're joined by Caitlin Sinovic, and she's going to be presenting to us on understanding and addressing brain injury. Obviously, many of the people who are joined on this call work in direct services with individuals who are in our housing programs, some coming from different circumstances. Some people are transitioning out of nursing facilities or institutional settings. Others are perhaps experiencing homelessness, and even others are living in group homes or residential rehabilitation facilities. So it's a very broad array of individuals in our programs. And some people that we work with may or may not have experienced a brain injury, might be receiving services through the brain injury waiver program in the state, but there could be people who have a brain injury and perhaps it has not been identified. But there are certain signs and different cues that indicate to us that someone is potentially experiencing a brain injury. And also there are services for this population. And it's critical to get them connected to the resources that they need in order to thrive in the community as well, if indeed they are in need of them. So I'm happy to have Caitlin here to present. For those of you joining us by phone, I will go ahead and reiterate this again. If you want to raise or lower your hand because you have a question, the number is to dial *9, and you should receive a prompt. Once you've done that, I will request to unmute you, and then you have to press *6 to mute or unmute. For those of you who have a question and you're joined by the computer, you can type any question you might have in the Q&A, and I will hold all questions until the end. If you have a technical issue, please put that information in the chat, or if you just want to talk and exchange information with colleagues, put that all in the chat. And if you need to raise your hand because you want to ask a question that way instead of typing in the Q&A, there is an item, a raise hand icon at the bottom of your screen that you can select from. Okay. All right, Caitlin. Well, without further ado, happy to have you join us today. Thank you.
Yeah, great. Thank you so much, Chelsea. I really appreciate being here today. And the presentation that I'm going to share is really kind of what we call the Brain Injury 101. So, and part of the reason I'm acknowledging that is that there's a lot more of all of the things I'm going to talk about today that we could dive into very intensely. I think any of these things could really warrant their own session. So I'm just going to acknowledge this is really an overview, and hopefully that you'll leave with some introductory resources and strategies for yourself to be able to work better with folks who have a brain injury within your programs. This is just a little blurb about me. I won't read it out loud. I'm an occupational therapist, and I currently work for the National Healthcare for the Homeless Council and do work with NASHA, the National Association of State Head Injury Administrators, which is who has brought me here to you all today. I'm also a former Marylander, so I lived in Baltimore the last 9 years before moving back to Florida to be closer to family during the pandemic. So happy to be back with you all Maryland-based folks here today. And this, just as a plug for NASHA, is a really wonderful resource regarding resources and information related to people experiencing brain injury. It's helpful for systems and services, but it's also really helpful for individual providers. There's a lot of resources on the site and tools that might be helpful to you all as you're doing your work. So the objectives for today are really to help understand the prevalence of brain injury and why we're having this conversation today, even if you're not a brain injury specific provider. and also to help understand some resources and strategies to help engage with folks with brain injury that may be in the programs that you're working in. So this is a little bit of the overview of what we're going to be talking about today. As Chelsea mentioned, we're going to really do questions at the end. However, if you're like me, you might need to write something down as you think of it. Please feel free to throw questions in the chat or the Q&A, and we can pull from that for the question and answer part at the end of the discussion here. So the first part that I'm really going to talk about is risk factors for brain injury and understanding why we talk about it in services that are not brain injury specific and where it's showing up and who are folks who are at higher risk for brain injury. And a lot of these folks who are at higher risk are also at higher risk for not receiving treatment and not being diagnosed with a brain injury. So it's sort of this really crossover of issues that happens here. So with people and individuals experiencing homelessness, there's a lot of data that's been published recently that identifies that almost 50% of adults experiencing homelessness have sustained a brain injury at some point in their lifetime. And there's a really high correlation between mental health symptoms, and a history of brain injury in people experiencing homelessness. And it's also critical to note that about 25% of these adults who've experienced a brain injury have sustained a moderate to severe TBI. I'll talk about what that means in a little bit, but really that means that there may be more significant challenges as a result of that. And a really astounding feature and fact is that almost 50 to 90% of folks who are homeless, who have a TBI, that TBI happened before they became homeless. And that's why part of screening and recognition of brain injury is so critically important, because if we can intervene after somebody's had a brain injury, we can potentially change their housing trajectory and maybe even minimize or eliminate the possibility of the person becoming homeless. Individuals who and families who have experienced domestic and interpersonal violence are also at a much higher risk of experiencing a TBI and is very much underidentified for the same reasons that other injuries are underidentified. Folks, when they have an injury related to interpersonal violence, often don't seek medical care unless it's very severe and may not reveal the full extent or information behind what happened to their injury. And so sometimes if somebody had an experience where maybe they broke an arm, but they also fell or sustained a minor head injury, they may not know that because there may not be facts around all of that, and they may just get treatment for the arm. The unfortunate part about this as well is that then people don't recover as well. So individuals who experience a TBI from violence often don't recover because they don't receive the same depth of treatment that they might otherwise receive. One study of 5 domestic violence agencies in one state found that 85% of survivors had experienced a blow to their head and 50% experienced more than they could count. So that's really, really significant and has a lot of implications for recovery and how people are able to engage in services. And the more severe the extent of interpersonal violence, the higher the risk of experiencing a brain injury. Additionally, individuals who are incarcerated also have higher rates of head injury, and just like these other populations, are more at risk for having head injury, not receiving treatment for it, and not having it documented in their chart. But there's evidence to show that individuals with a history of TBI might have a higher risk of reoffending. And this is really related to where on the brain the TBI occurred. There's certain parts of the brain, such as the frontal lobe, that contribute to how well we control our behavior and our impulsivity. And if that's impacted or impaired, it's a lot harder for people to regulate themselves or abstain from engaging in some dangerous behaviors, which then may make them more likely to be reincarcerated or violate certain rules such as probation or parole. And juvenile offenders especially are more likely to have a TBI than the general teenage population. And then individuals living in poverty. So this may be a cross section for folks experiencing homelessness and domestic violence and who've been incarcerated, but as a whole, those with lower income are actually more likely to have a TBI than the general population that is not living in poverty. And unfortunately, again, because of our healthcare system and access to healthcare services, even if they go to, say, the emergency room to have the TBI treated, are going to be less likely to have access to or be referred to rehabilitation settings that are going to address some of those symptoms of TBI, and they may not be able to engage with that level of intensive support. And similarly, there are caregivers. A lot of the brain injury world relies on caregiver supports to help people in the recovery and reintegration process, but individuals living in poverty don't necessarily have support networks that can provide that level of support to them, and then are also less likely to have access to adaptive equipment, devices that might aid in recovery. And then part of that trajectory potentially for becoming homeless, right? If somebody has an injury that impacts their ability to return to work in the way that they were working before, employment can be impacted and further result in additional poverty and limitations in income. And then veterans in the community, and this is an interesting one because veterans and those returning home after the most recent wars in Iraq and Afghanistan really brought to light around what was happening with head injury across folks, and not necessarily just like having a fall and an impact to the brain that we might think of, or a car accident, but some of those other ways brain injuries are caused just with repeated blows to the head, other impacts that build up over time. One of the challenges, though, and is being recognized by VA services and the Department of Defense, but there's still not great solutions to it, is that there are many, many individuals who served in the military who are dishonorably discharged, likely due to behaviors related to their brain injury or post-traumatic stress disorder. And because of brain injury or PTSD can result in those impulsive behaviors, lack of behavioral control, sometimes increases the risk of substance use. Those are reasons that folks may be then dishonorably discharged. And when someone is dishonorably discharged, they're no longer eligible for VA benefits. So people no longer have access to any income-based supports, to disability determinations, or even just VA for the healthcare. So they found that almost 10,000 former service members have been discharged following a TBI, and those individuals did not have access to any of those support services that their peers who also served in the military did. So even if you're not working in the VA and veteran services, you may come across folks who have served in the military who did sustain a brain injury but didn't get the treatment they needed for it, and have thus then had a lot further complications. And a lot of this, again, centers around increased likelihood of homelessness, criminal justice involvement, or engaging in substance use, or developing mental health disorders. So there's a lot of crossover there. So if you have someone who was dishonorably discharged from the military, it's maybe worth screening them for a history of brain injury to see if that's part of what happened in that case. And then finally, another subgroup that has a high prevalence of brain injury that's not well treated are refugees and asylum seekers. So folks moving to the US as a result of violence or instability in their country. Often then, if the TBI happens at a time of instability, folks don't have access again to healthcare treatment to be able to address that or even identify it. And this occurs alongside having traumatic PTSD and experiencing stressful and traumatic events. And those things compound on each other and can make the effects of the brain injury worse. Depending on where individuals are from, there may be different cultural responses and perceptions of what brain injury is, and therefore somebody might not feel comfortable disclosing that they've had an injury, even if it was diagnosed, recognizing that it's happened, or seeking out treatment. And then for those who come to the US, Western healthcare system in the US looks very different than a lot of other places in the world, and it can be really difficult and challenging for folks to navigate, especially if they have come here and they don't know English yet. Learning how to navigate a complex system in a secondary language can be really, really difficult. And if folks are making multiple transitions or part of a resettlement process, then they're not connecting with the same providers over time who may be able to uncover this. So again, it's another group that really would benefit from having routine screening to ensure that there's not something going on there and a better level of support happening. And why does it matter? Why do we need to know about untreated TBI, and why does that relate to the work that we're doing? The data shows that untreated TBI really exacerbates social and health inequities. Having a TBI that's not treated and diagnosed and not receiving services for really can sort of start a domino effect for decreased health and decreased housing stability, and really decreased ability to engage in the community in the way people desire. And what it means for folks with brain injury is that, if they're in an abusive situation or they're living in shelter settings, it can be really, really challenging for them to to do the complex tasks needed in order to transition out of that particular setting, or to figure out and navigate resource systems. Our healthcare system is difficult, our housing systems are often complicated, and for someone with brain injury, it can be really challenging to navigate those. And additionally, if people have a brain injury and have a related behavioral or impulsive or any sort of issue there that makes them kind of for lack of a better way of saying it, like a difficult person to be around, they may not be allowed in programs. They may fail out of programs. They may be kicked out of programs because they have a hard time following rules and procedures, but it's not intentional and a result of their brain injury. And really, it's important to identify these because oftentimes a brain injury can be hidden and it can look like other conditions, and then folks don't respond the same way to treatment. So you might be using strategies that work really well with a certain population, and this person isn't responding to that and isn't getting better. And sometimes a hidden brain injury is part of that. And sometimes people, again, I use the word difficult. I don't actually describe my clients that way, but people can be categorized as difficult, and therefore make it providers don't necessarily want to work with them as much, or people have a harder time engaging with them. And again, those behaviors may really be related to an underlying brain injury and not something intentional that the person is doing. So when somebody has a brain injury, and for the purposes of this, I guess I should have put this as a slide at the beginning. When I'm talking about a brain injury, you'll see in the literature, you can see TBI, which is traumatic brain injury, or just brain injury. There's also a type of brain injury called the word just left me, acquired brain injury, which is something like having a stroke or a neurological condition that causes a brain injury. A traumatic brain injury is where there is a blow or something happens to the head through a fall, or being hit by something, being in a car accident and hitting your head. Something in that regard is considered a traumatic brain injury. So when folks do have a brain injury, and that's more of what today's session is focused on. So when folks have a brain injury, the most common effect of a brain injury is a cognitive impairment of some sort. And cognition is very complex, and there's a lot of pieces to cognition. But what that looks like is somebody has difficulty concentrating, a hard time paying attention, a hard time remembering information, trouble with judgment. So knowing when to stop talking, reading social cues, what is safe, what is not safe. And because of that, then too, also really having a hard time following directions, whether those are verbal directions or written directions. That's a part of executive functioning, is being able to start, work through, and stop a basic activity. And people with brain injury really are affected in being able to do that. And the harder and more complex the task you're asking them to do, the more of a challenge they'll find it to be. And this results in people having a hard time in social interactions, learning new skills, and learning how to do something new, or even relearning something, problem solving, and figuring out, if this doesn't go the way that I expect it to, what could I do differently? How could I work around this? And then managing multiple complex things at a time. There are folks, who are not able to cook at the same time as the TV is on, or it's the individual that is cooking and the phone rings and they walk away and they never go back to cooking, and that causes issues with smoking and fire, all of that. And that's because managing those different things at the same time are really quite challenging. In addition to a brain injury, there are a lot of things that can impact our cognition just as a human being. There's medical conditions. So if somebody already had a developmental disability, HIV, especially progressive HIV, the cognitive impairments tend to not happen unless the person's illness has progressed. Anyone who's using substances, both currently and in the past, may have effects on cognition. And then anybody who also has a co-occurring mental illness or mental health diagnosis. And usually cognition changes if the acuity of the condition changes. So if somebody is in a really acute depressive episode or is experiencing really heightened psychotic symptoms, cognition is going to be more impacted than when they're more stabilized. And then anyone who's had a significant medical intervention or been in the ICU recently, which would include anybody who needed hospitalization as a result of COVID over the last couple of years. And then there's also data to show that the presence of chronic conditions can impact cognition as well. Those are things like diabetes, cancer, hypertension. So anyone who's managing multiple of these conditions may have more effects on cognition. Environmental, so what's happening around us can also affect our cognition, whether or not we're eating well and have nutritious foods, whether or not we have stable housing, feel safe in our environments, get adequate sleep. If we've experienced trauma, both recently and historically, whether we're undergoing high levels of stress, and literacy also has a factor in cognition and cognitive skills. And then TBI can also impact, and I kind of mentioned this, impulsivity, people, being quick to do something, respond to a situation, not always appropriately, not always safely. It can also limit awareness of social cues. People can have very limited frustration tolerance. So they might have the cognitive ability to do something, but can't tolerate something that's challenging or takes a long time, or they don't get right away. And then for some folks, again, depending on where their brain was impacted, may have trouble making preventing themselves from saying inappropriate things, doing inappropriate things, or having inappropriate interactions with folks. So that might be the person who every time they see their case manager says, "Hi, beautiful." And it doesn't matter how many times you said, "No, my name is such and such," and set the boundary around, you can't call me beautiful. Like, that's a nice thing to say, but you can't say that, right? Every single time they're not able to do that. Somebody doing that is probably likely somebody who has a brain injury and really needs to have some of that social stuff addressed. So I've talked a lot about what is brain injury and where might it crop up in different populations. So the first thing to do to understand whether or not somebody has a brain injury, if you have access to the medical chart, you can certainly look. But if it's undiagnosed, one of the biggest things that we need to do is screen. Really what's recommended is to kind of screen everybody that you come across, not just indicators, somebody who might be showing signs and symptoms, but recognizing that as providers, you have to do a lot of different screenings, fill out a lot of paperwork, document a lot. Screening everyone may not be the most feasible, but it really is important because it can identify a history of brain injury that the current providers don't know about. And screening, this verbal screening that I'm going to show you in a minute, is the best way to identify it. Somebody who had a brain injury 10 years ago, doing like a brain scan or referring to neurology is not necessarily going to show you that that's happened unless there's been really significant damage or a part of the brain was actually removed as a result of it. A scan of some sort isn't really going to show you that. It's more the history that's going to be more critical. Anybody who didn't get treated for their TBI is not going to have that in their medical records. And for a lot of folks, records may not be available, especially those who are experiencing homelessness or housing instability, who've moved across states, people who were in the military, who are no longer in the military, are really going to have a hard time getting those medical records, and providers are going to have a hard time tracking that down, especially if you don't know where they got services before. And it's important because the effects of TBI can affect how a person engages in the programming that you're providing. And if we're not recognizing and treating brain injury, then folks are not going to do as well in our programs. And clinically, why this is really helpful and relevant is that it can rule out anything that might appear to be behavioral or motivational. Again, sometimes it's a little bit easier to understand or be supportive of a person if you realize, like, something happened in my brain to make the person act this way, instead of feeling like they're just doing this to annoy me. They're being really difficult today. It sort of shifts that script to thinking this person is having a hard time and how can I support them? And those cognitive impacts are going to be woven throughout their day-to-day lives, and it's going to impact their abilities to live in the community, do what they want to do, return to employment, take care of themselves, whatever that might be. If you know there's a brain injury, that can help you better identify strategies that can be put in place to help that person succeed and thrive, and really inform your treatment plan and what your goals are in a way that's responsive to what's happening with the person. So as I mentioned, best practice would be to screen everyone who comes through your program. Realistic practice might be that we only screen people who really show indicators. And this is a list of some of the indicators that you can look out for. So anytime somebody brings up a head injury in conversation that they might have had in the past, that's a great reason to screen them to see what really was going on. Anyone who has a history of any sort of abuse or trauma, anyone who's had a physical assault recently or in their past, even if the injury if they describe the injury in a physical way, like such as impacting their arm or their leg, whatever that might be, it's always good to screen because there's likely a chance that there was a head injury involved as well. Especially for older adults, anybody or who's on a lot of medications, anybody who reports feeling dizzy, who is unsteady when walking, like visually you can see that they're very unsteady, or who has a history of falls or tells you that they've fallen at home, is a really good reason to screen. And for that reason, then including people over the age of 62, especially for people who have more medical issues. Anybody who has a history of seizures or uncontrolled seizures, in part, seizures increase the risk of a head injury, but seizures may also be a result of somebody's head injury that was really undiagnosed. Somebody who has a substance use history, both current and previous, even if they've been in recovery for a long time, somebody with a history of incarceration. And then from your clinical observation, somebody who has issue with these cognitive things, right? They don't remember what you tell them. People have a hard time paying attention, who are disorganized. I kind of think of the client who like comes to me and sits down and they open their bag and it's just like full of papers and receipts and anything you can think of, right? And they're kind of digging through trying to find what they wanted to bring to show you or to work on, and it's just kind of a disaster. That can indicate maybe that there's something else going on. And then for folks with mental health symptoms, it can be that there's sort of this sequelae, this like grouping of symptoms, but it doesn't really cleanly fit any real diagnosis. It kind of looks a little like this, and maybe there's some motivational issues and some disorganization issues, but it doesn't really fit a clinical diagnosis. Sometimes the reason is that it's actually a brain injury and not a mental health issue, or a brain injury and a mental health issue happening at the same time. So there are several different ways that people can screen for brain injury. The one I'm going to talk about today is the OSU TBI ID, which is a bit of a mouthful, in part because it was really developed with and for the populations that I've talked about today. It's a really easy, quick tool to use, and best of all, it's free. And there's a lot of resources available around it. The other screening tools listed here are a lot more comprehensive and complex, and can be more of a challenge to implement in day-to-day practice. So this is just an overview of what the TBI ID is. One of the reasons why it's recommended is that it's not clinically worded. So if you say to someone, have you ever had a head injury? Do you have a history of brain injury? They're probably going to say no, especially if it was never diagnosed or they didn't get treatment for it. Instead, this really phrases the questions around experiences that people had that may have been a brain injury, and helps you determine that on the back end and really getting a history of the person from their perspective. Even though it's a self-report measure, it's actually highly valid and reliable, and has done a lot of testing, including people who were incarcerated or experiencing homelessness. Apologies, I'm getting over a cold and I'm hoping not to cough at you this entire time. One of the other benefits of the OSU is that there's really extensive online support. So I'm going to just give a little bit of an overview of it today. If you're really interested in implementing the tool, I would recommend doing more intensive training just to feel really comfortable with implementing it. But all of that is available online, including videos, the forms you can download for free there. If you're interested in reading the publications about it, all of that is available at the website listed here. So this is what the form looks like, and I do have to say that the form itself is a little bit more confusing looking than it actually is to implement in practice. Apologies. So you start with step 1 on the very left-hand side, and you go through and you ask the questions 1 through 5. And if anyone answers yes to that, then you record it under the part that says step 1, the cause of that. Step 2 then is you go back and you go into detail about each of the causes of that, and if the person experienced a loss of consciousness, or you can use the terminology "were you knocked out," which is a lot more understandable and familiar to a lot of people. Sorry. Okay. And step 2, that gets entered in there. And then step 3, you do only if the person has an experience of repeated injury. And so following this guide, you ask the questions in the order that they're presented here, gathering some details about that. And that will help you determine sort of potential history of brain injury, impact of injury, and what type of injury it might have been. So the form itself, the backside allows more room. The form itself includes some support for interpreting findings, which include if the worst level of the injury that occurred, if the injury happened before the person was 15, if there have been multiple, anything that's happened recently, and then any other ways that their brain function might have been impaired. So in my practice working with people experiencing homelessness and co-occurring mental health and substance use, anytime a substance use disorder came up, that was something that I put in there because that's really going to impact the brain and cognition here. So when we're talking about the worst injury, that is the level of loss of consciousness the person experienced when they had the brain injury. So one is there is no history of brain injury. Two is that there may be a mild history. Three is that there is a mild injury and a brief loss of consciousness less than 30 minutes, where a 4 and a 5 are the more significant ones, where there was a loss of consciousness greater than 30 minutes, and in the case of a 5, greater than 24 hours. And so you can assign this number based on the worst injury that somebody reports to you on the screening tool. Additionally, in terms of interpretation, the person is likely to have ongoing problems if any of these things are present, which is the list I read earlier. So if somebody had a mild injury 3 years ago that was maybe a level 2 head injury, they are much less likely to have any of those ongoing cognitive problems than somebody who maybe had a significant brain injury at the age of 10, somebody who was a boxer for 10 years and didn't wear head protection, somebody who was in a car accident at some point in their life and was unconscious for, a day at a time. Those are the folks that are going to have a lot more ongoing problems. But a person may have a, kind of a low threshold brain injury, maybe a 2 or a 3 on that worst scale, but they have a lot of other cognitive issues going on. And that might then further impact whether or not there's really long-term implications from that. So this is just an example of a completed one, just so you can kind of see what it looks like. This is a client that I worked with. So as you can see here, this individual had a lot of falls, which is one of the indicators for screening, was that he was having all of these falls. Digging in further really revealed that there had been a few significant head injuries. As you can see, he had a bike accident and at some point was hit by a truck. In both cases, he sustained a loss of consciousness that was 30 minutes to 24 hours. And one of those was actually relatively recent. He was a gentleman in his mid to late 50s. So here in the scoring part, identifying what those indicators are that might indicate an ongoing problem. He had the worst injury, so he had 2 head injuries that were over 30 minutes. One of those head injuries occurred before he was 15. So, and then you can see the number 4 there is the level of the worst injury. And then other sources, so things that I noted might be problematic and impacting his cognition: a history of substance use, he was currently drinking, and then he was continuing to have these falls, which would increase his risk of hitting his head. So again, diving into doing it, it's really great to watch somebody administer it once or twice through those views. And I really recommend you to dig into that resource if screening is something that you want to do with your clients or with your organization, to get that training and get really familiar with the tool. And what you want to do with this information is, wherever you keep records for your clients, make sure to document the results of that. To put it in the record somewhere helps them with accessing services, but it also communicates to anybody else who might be working with the client, whether or not you leave your position and somebody else is taking over, or communicating among your team. And that includes documenting the type of injury and the worst injury that somebody had. And the process of how you record this can really just mirror anything that you do when you enter in other screenings. If you do the ESPER or an SDOH screening or the Prepare tool, whatever those might be, it can go in the chart the same way. And diagnostically, if you're a diagnosing provider of any sort, you can add the diagnosis of a history of brain injury to the person's problem list. There's an ICD-10 code listed there that folks can use. If you're not a diagnosing provider, then it's important to share this brain injury screening and the results of the screening with their provider, whether it be their medical provider, their psychiatrist, somebody that's seeing them regularly, and can then put it into their medical history and chart for them. Why that's important is that this opens the door then to these resources that we're going to talk about in a little bit in terms of rehabilitation programs, potentially accessing SSI benefits, waiver programs, housing options, whatever that is. The first step is to get this documented into the chart. And then the other piece about it is really just communicating this with your other team members, because once that history of brain injury is recognized, again, that helps you collectively as a team and a group be able to support the person in a better way. And think about what strategies are going to be helpful for them. Are there behavior and cognitive issues that we can address differently? How do we modify their treatment plan or their goals? How do we advocate for services for this person, and what services are they eligible for now? That can really change the conversations that happen as a team when we are communicating these. So it was a very brief overview of screening. Again, that's something I could talk about probably for an hour or two just on its own. But again, helps you identify, if you only are able to take away one thing from the session today, thinking about how we could start screening in your organization is a great first step. The next section I'm going to go into is more about accommodations and strategies. This is another space where I'm really just going to scratch the surface on the types of accommodations and strategies. It's something I could probably present on for 2 days. But again, I want you to walk away with something that you can kind of start to do right away, and opens the door to think about how we could dig in deeper. A lot of the strategies that I'm going to present today are really focused on cognition, because that's one of the trickiest parts to respond to and manage. So what is pictured here is the flow of cognition. And what that means is how we learn, understand, interpret, remember information. So at the very bottom, we have alertness. That is the essential key skill for us to learn and do anything with our brains. If we're not focused, none of the rest of these things in the chain are going to happen. Right? So if you have a day where, it's a really rainy day where I am right now, it's like I'm kind of drowsy, right? I'm not going to be able to retain as much information if I'm not awake, right? And engaged in where I am. After that is attention, right? So I'm alert, but now I have to be focused on what I'm doing. If I'm not focused, then the information isn't really getting into my brain, right? If I'm alert, I'm focused, the information comes in and then I process it. My brain is figuring out what to do with this information. Where should it go? How should it be filed? What do I need to do with it? Oh, it's something I need to remember. Okay, I'm going to put it in the memory part of my brain. Remembering information does not happen if those bottom 3 pieces are not there. So if the brain injury or anything has affected the person's alertness, attention, or ability to process information, they're not going to remember. A lot of times we identify things as a memory challenge for somebody, but it might be the case that their memory is okay, and it's one of these other things that's actually affected. And if we adjust that, that their memory is actually, they're able to remember information. At the very top is executive functioning, which is being able to do those complex processes, going from step 1 to 5 of an activity without getting distracted, without getting confused or disorganized, is part of executive functioning. And it's also important to remember, in addition to a brain injury, anything can affect our ability to learn, right? If you have a bad night of sleep, if you didn't sleep well last night, you might be thinking today, like, I don't understand what she is saying, right? Like this all may be going over your head, that if you had had a good night of sleep, it might feel a lot easier to pay attention to. Again, if somebody has co-occurring mental health symptoms, that's going to affect their ability to learn. If you're feeling stressed or distressed, that's going to affect your ability to learn. And then similarly, especially for our folks who are on a lot of different medications and their side effects can cause a lot of drowsiness and things that make it hard to be alert and pay attention and remember things. So it's always important just to check in when you're working with someone, like how they're feeling, because maybe there's cognitive impairment, but they also had a really bad night of sleep, or they had a really stressful bus ride to get to you, that it might need to take a moment just to center and reset before you dive into doing any of these particular strategies. So where do we start when we're talking about accommodating somebody with brain injury? really the biggest thing to start with is compensatory strategies, which means we understand that there's a cognitive impairment, there's a gap happening somewhere. So we're going to find a way to fill that gap for the person. It's not necessarily about improving the cognitive skills of the person, it's about modifying what's going on around them to be able to do that. Over time, you can maybe work on the cognitive skills, but compensatory is sort of the first thing to do. The other thing to think about, especially from the program perspective, is thinking about how do we make our environment supportive and accessible. In the same way that we might build a wheelchair ramp and an elevator for somebody who is using a wheelchair or a mobility device, we also need to think about how set up our systems for people who really have challenges with doing complicated tasks. And these next couple of slides, I'm not actually going to read really to you. I've included for your reference, but the biggest reason I've included them is really to recognize that there are things that you are already probably doing that work really well for your folks with brain injury. So strategies like motivational interviewing, goal setting, identifying what the person perceives to be their challenges, those are all really effective for the person with brain injury. And maybe you just use them a little bit with a brain injury perspective. So asking the person, what helps you remember information? What makes it hard? And using that cognitive lens. But these are tips and tools that most of you are probably already using in your practice. Similarly, setting ground rules and boundaries, again, is a key part of practice for a lot of service providers. The most important thing with brain injury is being consistent, being prepared for an emotional response or outburst, especially when somebody might not understand the information. But again, using strategies, trauma-informed de-escalation, problem-solving skills can really help you engage, de-escalate, and then get that person to a calm space where you can think about what to do differently next time and identify what the triggers are. Some folks really respond to their environment, right? So if you're in a noisy place or you're in a meeting and your phone keeps going off, that might be the trigger for the person as opposed to what it is you're saying. And then person-centered planning is sort of the brain injury term. But again, as a case manager, as a mental health provider, as a housing provider, these are things, again, that you're probably already in your toolbox to use and maybe just need a little bit of adjustment. So when you're having the person identify goals, using the SMART goal method makes really tangible, specific goals that can be a lot easier to follow than sometimes these broader ideas. Oh, I want to go back to work. Well, what does that mean? Like, what do we need to do first? Do you need to learn how to be comfortable on the computer? Do you need to learn how to use the phone? SMART goals can help build to those bigger goals, and then helping you identify what resources are needed to meet those goals. So the strategies that are listed here in the PowerPoint, and as Chelsea mentioned, these are going to be available to you all. I want to make sure we have time for questions and resources. So I'm going to probably go through these a little more briefly. And again, potential follow-up, we can dive into these strategies a little bit more, and there's other places to get some of that training. But the strategies I'm presenting are ones that we call external strategies. So as I mentioned, they're not changing the person's cognition, but they're adapting the environment to help the person be more successful. Even though they're external strategies, you want to make sure that you're engaging the client in the process to identify what they are, to provide support for using them, and talking through whether or not the strategies were helpful after they've used them. So one of the biggest, easiest ones is visual reminders. The biggest thing to remember about visual reminders is that everything is less effective if you overdo it. So if you can imagine, oh, I'm going to write myself a Post-it note to remember to do something, right? And I put it on my front door before I leave the house. A big pink Post-it note on my front door is definitely going to get my attention before I leave the house. However, if I put up 10 bright pink Post-it notes on my door to remember different things to do before I leave the house, it's going to be harder for me to recognize which of those is most important. And over time, I'm probably going to start ignoring them. So really identifying just one or two places, what's really important. I had a client with a pretty significant brain injury. We put up a stop sign. He had two entrances to his kitchen, really at eye level at the exit point of the kitchen, to make sure that he stopped and turned around, and before he left the kitchen, made sure that the refrigerator was closed and the stove was off. But just that simple stop sign alerted him to stop, do a visual scan and figure out if it was safe for him to leave the kitchen at that moment. That's what made sense to him. So it's important, just putting up a stop sign in somebody's kitchen doesn't necessarily trigger the same thing for everybody. So making sure the person understands what it's for, and that it's meaningful to them. Checklists, again, can be really, really helpful. Just like the visual cues, the simpler the better, especially when you're starting out. If you have a 20-item checklist, that's very overwhelming feeling for all of us. And I think, again, it's going to be less useful. So something really simple that highlights the key things to be done. You can laminate it so the person can check it off and erase it every single day. You can print a bunch of different examples that people check off. They could just be visual. You can have magnets to put on it, whatever, again, is going to work for the person, just to make sure that they're checking off and doing the important things they need to do, and making sure that they're kept in a place where the person is going to look at them. This strategy might take a little bit more time, depending on how well organized someone is already in their space or how problematic it is. But organizing the space can be really, really key and essential. If somebody's really living in disorganization, maybe they have hoarding issues, whatever that might be, you might start, again, in sort of triage what's most important, keeping a space by the front door clear so that their keys are there, their wallet is there, their phone is there, and that's what they leave every time they go out the door, kind of working your way back through the rest of the house. Kitchen items, wherever areas are really problematic for the person, finding a kind of a home base for whatever the person's item might be, and that is always where the item returns to so that they can always find it. And then using natural routines. So this is something that we might automatically teach ourselves to do, but after a brain injury is not so automatic. One great example I always did for my clients who had medications twice a day is, take your meds when you brush your teeth. Something that you're already doing in your routine, pairing the new task with that together. Like, oh, I always read the Bible before I go to bed at night. So maybe that's where I'm going to keep my pill box to remember my medication, or my phone charger so I remember to charge my phone. Bigger, larger tasks, right? Like, I know that I get my SSI on the first of the month. That's the day that I pay my bills, so that I'm not trying to remember to do it throughout the month, and not avoid or forgetting to do it. And then blocking out distractions. So recognizing for the person when maybe they need to do things to minimize distractions. When you're cooking, turn off your phone, because if the phone goes off, you're going to get distracted and it can be a problem. Don't have the TV on while you're trying to pay your bills, right? Figuring out what those distractions are and trying to minimize that for, again, things that are really priority, or harder for the person to do. And then decreasing visual information. I think this is such a useful one when we're talking about things like paperwork, which is really overwhelming and hard to navigate the more complicated it is. So simple is, you can see here, these are instructions on how to change a light bulb. And at first you're like, oh my gosh, how are there so many steps for changing a light bulb, right? Feels overwhelming. The simplest thing to do, right, is just put a blank piece of paper over the rest of it and focus on the step that you're on. Looking at this feels much less overwhelming than all of those bullet points that were below. Then you can move the paper down, add another piece of paper on top if you need to, just to highlight what's key. That can really help people get through. Again, I've done a lot of SSI paperwork with clients, get through those complicated pieces of overwhelming paperwork that we have to do. The biggest thing when we're learning strategies is you're going to have to repeat it. One time is not enough. It's not enough for any of us, but especially somebody with a brain injury, so that they're learning it while they're alert, while they're attentive, giving them time to process it, and really making sure it finally encodes in their memory. When you're working with them, remove as many distractions as possible. If you're working with somebody in a group home setting, can you talk with them in their room instead of the living room where there might be other people coming in and out? Where are spaces that you can really find that are going to limit the distraction, to really help the person focus? Talking in short sentences, being as direct as possible. These are really helpful for the person to, again, hear the information and process it, and then be able to do what you're asking them to do. And practice. So practice the strategies when you're together. If you're in an office, practice them together in their home, in the community environment where they need to use them, and then help them, practice together, and then give them homework to practice without you, so that these become more ingrained in their daily routines. And just recognize it may take some time. The stop sign strategy that I mentioned with the client in the kitchen, we had to work on that for a while. It was probably about a month before it became really, really effective. But then when it was really super helpful. But it's not something that happened right away. And just how the person feels is going to be remembered almost more than the content. So that rapport building piece and connecting with the person and being positive and reminding them of their strengths is going to motivate them to try new strategies and to keep coming back to you when they have problems. Again, apologies for all the coughing in your ear today. So here are the resources section. And the tricky part about resources is that what the person is eligible for is going to be dependent on all kinds of things, what their health insurance status is, who they're covered by, where they live. There's going to obviously be more resources in the more urban areas. There's not as many resources in the more rural areas of states. And kind of what that diagnosis and that traumatic brain injury history is. All of that being said, I'm going to provide some overview of resources available in Maryland that can, again, help you build out some ways that you can help individuals. So for starting, when you're screening and diagnosing somebody with brain injury, that can support an SSI, an SSDI case, or eligibility for Medicaid and Medicare. The diagnosis personal history of brain injury alone may not be enough to get somebody SSI, but if you're combining that with other mental health issues, or other developmental disabilities, sometimes it strengthens the case as to why maybe the person can't cope with some of the other stuff that's going on. The diagnosis then maybe make the person eligible for rehabilitation services and to have those services be reimbursed by their insurance provider. The other thing is that you can then connect the person with support groups and other consumer-based activities that would connect them with somebody with lived experience where they can really share on these experiences. So what are some of these common referrals? So when we're talking about rehabilitation services, if you feel like there's a pretty significant impact of brain injury on the person, referring the person for neuropsych and getting them on the list as soon as possible. In most places, I think it's 6 to 12 month wait to get into neuropsych. It's important because it gives you a really comprehensive evaluation and diagnosis, which can, again, increase some eligibility for folks. So especially if there's a lot going on and you think the person really needs to be eligible for a lot of different services, neuropsych is a good recommendation. Neurology is actually only a helpful referral if there seems to be ongoing medical concerns, frequent falls, seizures, tremors, kind of more of those physical manifestations. A screening for positive on a TBI screener doesn't necessarily mean the person needs to see neurology unless there's something else going on. Occupational therapy, so the rehabilitation providers, OT, PT, and speech, all address different things, and a lot of folks with brain injury will get all of these 3 different services at the same time. Occupational therapy works on daily life routines, daily activities, helps adapt and compensate for cognitive impairment, physical impairment, if there is that co-occurring as well. Speech therapy can be really helpful if there are speech, language, and cognitive impacts. So somebody who might have difficulty finding the right word, getting the right words out, or who seem to have difficulty with comprehension, not really understanding what you're saying, even if it's really simple and direct language. Speech therapy can do wonders to help folks with that. And then physical therapy is really helpful if there's mobility, movement, motor impairments. So tremors, issues with balance, issues with walking and gait, issues with stiffness and pain. Physical therapy can tackle a lot of that, and that may be due to brain injury. For any of these services, the person does need to be connected to a primary care provider who can then make the referral to ensure that it's covered and reimbursed by insurance. And most Medicaid programs will cover all of these, and folks who are dually eligible, then any of the copays will be covered by Medicare, Medicaid. Additional resources, there's the Brain Injury Association of Maryland, which is a fantastic organization. There's a really great website that has tons of information, training for providers, resources for consumers and families, information about how to access the Maryland Brain Injury Waiver and housing support services. If you have a client who you think might be eligible for those, you can contact BIAMD and they will help you navigate that resource. And again, the website has tons of information on it. They also have an annual state conference, and their conference is happening in May. So if you're really interested, again, in diving into more about brain injury and how to support folks, I'd recommend attending that conference. It's usually really well put together. There's also the Maryland Behavioral Health Administration has a specific page linked here regarding traumatic brain injury. Again, goes over different services that are offered in the state of Maryland, and as well as some basic information, fact sheets, information on screening tools, and some professional training materials to help you dig into information a little bit more. These are links to other resources. Again, you'll have these with the slides, so I won't read them out loud to you because I did see a couple of questions. I know we're close to time, but I'm happy to stay over just a couple of minutes because I know we got started a little bit late to make sure that folks have their questions answered. So I will open it up for any questions.
All right, sounds good. Can you hear me?
Yes.
Okay, great. Sorry that my video is not working out. Let's see. So it looks like I have Lilia Solanco has their hand raised. I am going to allow you to talk, Lilia, and I am asking you to unmute yourself so you can have your question answered. So you should be able to unmute yourself, Lilia. Lilia, can you hear me? Okay, maybe we'll come back to Lilia. Looking at the Q&A, people asking for copies of the slides. Are there any other questions?
I know it was a lot of information, so I definitely do recommend when you get the slides, just reviewing it in chunks. You don't necessarily, as a good learning strategy, have to learn about screening and strategies and resources all at once. But kind of start with what is really pertinent to you in your practice right now.
Marianne said there's no microphone button to unmute. I see you have your cat, Caitlin.
Yes. Happy visitor for today.
Nice. Yes, that I do know that you have to raise your hand, so I know that you want to speak, and that is how I go in to ask. I can click ask to unmute, and then you should be able to unmute yourself using the microphone at the bottom. Looks like, oh, okay, great. You already picked up on this one, Caitlin. Miranda asked for the resources slide again. Yeah, this was an extremely helpful presentation, Caitlin. I really, really thank you for giving us your time today. And I learned a lot. I have actually have a close friend of mine who acquired a brain injury, gosh, maybe a year and a half ago. And this was extremely helpful for me, even, as his friend, just, trying to navigate what services might be beneficial for him. It really changes your life in a significant way.
Yeah, and oh, I see a question which kind of relates to how I was going to follow up too is, how life-threatening can a TBI be if untreated? And the short answer to that is it
Mm,
depends on the severity of the TBI. So if somebody has an extreme TBI where there's intracranial bleeding, so bleeding inside the brain or bleeding inside the skull, that's actually quite life-threatening, as well as if there's any sort of inflammation. So your brain has a little bit of space between your brain and your skull, and there's fluid that's in there. But if there's any sort of swelling or change in that fluid, that can be quite dangerous to the brain as well. And then it also depends on kind of what part of your brain is impacted and how severely, whether or not, not seeking immediate treatment can immediately be life-threatening. Over time, it can be life-threatening because of the long-term complications that happen as a result, but you can also live very well without some of that functioning if that's immediately treated. So I had a client who had a pretty significant brain injury that resulted in a craniectomy. So they actually had to take out part of his brain and put in a skull, like a piece of metal for his skull, which is really significant, but he's someone who's living in the community currently with some supports. So it's possible to do it. It really just sort of depends on the type of brain injury that's happening and what part is affected. And I think the other important thing to note is just as you mentioned, Chelsea, your friend a year and a half ago is probably still feeling complications. Brain injury recovery can take a really long time. I worked with a client for almost 10 years who made substantial and significant recovery in that 10-year period time, but that is how long it took in order to really get to the point of where he had the severe injury to living independently in the community. So I think it's important to recognize, even with good treatment and rehab, it can take a long time to do that. And the only other thing I'll note, because I do know it's 5 after, is there's a couple case studies examples that I didn't think we'd have time to get to today, but they're plugged into the end of this, just to give an example of sort of trajectory of from screening to service and what that can look like and what the provider might do should you identify that somebody has a brain injury. So that's another resource embedded here as well. So
looks like Marianne did ask, are there more connections being made between intimate partner violence and the prevalence of brain injury? That's a great question.
Yeah, it is a great question. And yes, it is being more widely recognized. There's certainly some challenges in continuing to recognize it and kind of document that. The state of Ohio has done really significant in-depth work on this, and they're the ones who are producing the most data, and hopefully is a way that other states can replicate. One big recommendation is anyone working in a domestic violence shelter to have universal screening for this reason, to get people connected with the right supports and services and potential treatment as needed, especially if an event was really recent and might have been the reason why the person left. So there's a lot around that, but it's still highly underreported. And the brain injuries look a little bit different. So there's a high risk that somebody might have had a brain injury resulting from strangulation or asphyxiation, so lack of oxygen to the brain. And that looks different than if somebody had a blow to the head. And those subtle brain injuries are a little bit more prominent and harder to detect because you don't see the effect of that in this particular population.
Yeah. Another question asked by CK. Are drug overdoses considered brain injuries, and is screening recommended for persons who have overdosed?
Yes. That's such a wonderful question. I'm so glad that you asked that. Yeah, somebody put this equivalency for me at one point in time, and it was kind of brain changing for me to think about, that if somebody who has overdosed, the number of minutes that they spend unconscious for the overdose is sort of equal to the number of minutes spent at the bottom of a swimming pool if you're someone who's drowning. So if you have an overdose and it's 10 to 15 minutes before you're revived with naloxone, that's 10 to 15 minutes your brain hasn't been getting the oxygen that it needs. So this is completely underrepresented in the literature and the evidence, but something we know is happening in practice, that yes, somebody, especially if they've been revived multiple times or have an overdose all kind of close together as a cluster, that there's a very high chance of cognitive impairment and an anoxic brain injury. So anyone who's using substances, especially who has a risk of overdosing, that's screening is really recommended for that reason. If you yourself know or revive the person with naloxone, it's a great idea to do just sort of a cognitive assessment, or have their provider do a cognitive assessment regarding any potential lingering impacts.
Great advice. All right. I'm not seeing any other questions, but okay, great. Thank you, Celeste. I did get one request for a transcript of the presentation. I'm not sure if I'm able to provide this or not, but I will do my best. It just sort of depends on what Zoom is able to allow me to do, but I will certainly look into that. For anyone else who's interested in that, please feel free to send me an email directly. My first name, Chelsea, CHELSEA .Hayman, HAYMAN at Maryland, MARYLAND.gov, GOV is the best way to reach me. So thanks so much, Caitlin. This was a great presentation, and excited to learn more about all these resources that you provided. And the screening tool is really, really accessible. I mean, I'm excited to see what people are able to do with that. I think that, my suspicion is that more people in the general population have brain injuries than less, and they are not accurately screened. So if we can help people get connected to services that would benefit them, then that's a win-win to me.
Yeah,
So great.
absolutely agree. And I can endorse the screening tool. I've probably used it on over 200 to 250 clients. So I come from experience in having done it, and knowing that for the most part, it can fit pretty easily within a busy clinical day. So I hope that you all dig into it and start using it. So.
All right, sounds good. Well, thank you everyone for joining us on this somewhat rainy afternoon, and hope you guys have a good rest of your day. Take care.
Great. Thank you, everyone.
Thank you. Bye-bye.